Good morning, everybody. We're going to go ahead and get started. We have to finish up the previous PowerPoint and discuss Dubowitz and Ballard gestational age assessment. And then we'll move on to neonatal diseases. So I handed you a form that we're going to look at more closely, but let me just go through the parts of the gestational age assessment. So after one day, it says 30 to 42 hours after birth. So what they're looking for is to do an assessment. They call it neuromuscular maturity, to see how developed the newborn is. And then to figure out look at their physical signs and figure out how developed they are. From that testing or that evaluation, they're going to come up with the number of weeks of gestation. So according to what mom might say, you know, her last period was in January and it's now August. Is the baby really eight months gestation? So they'll do this test, compare it to what mom said to what they find during the testing and see if they're the same. So let me show you the different parts of it. So you see two big boxes. One at the top, it says neuromuscular maturity, and the one at the bottom says physical maturity. For the neuromuscular maturity, it looks at the baby's posture, and notice the more flexed their arms and legs, the more mature they are. Then they bend the fingers to the arm or bend the wrist to see how many angles, what the angle is. And if the wrist can bend all the way and touch the arm, that's a good sign of neuromuscular maturity. They straighten out the arm and then let it recoil. If it recoils, that's considered good maturity. Then they look at the popliteal angle, so that's the knee and how flexed the knees are. The scarf sign, they take the arm and they pull it across the body. And then they take the foot and they touch it to the ear, which is easily done when they're really premature, but it's not easily done when they're mature. So you see at the top, there's boxes for scoring. And then they do physical maturity. The no-go is when they look at the hair on the body. If there's hair on the body, or no, it's a sticky, friable, transparent. So that's the skin when it's not very developed. That's what their skin is like when they're born prematurely. Versus when they're fully mature, it says parchment, deep cracking, no vessels, mostly bald. Then they look at the foot. They're looking for creases. They're looking at development of the nipples on the breast. They're looking at their eyes and ears. When they're really immature, their lids are fused shut. And then when they are developed, their eyes will be open and their ears will have thick cartilage. And then they look at the genitals to look at the development of those. Okay, we're going to come back to this slide. So this shows how you don't have, this is a preemie that doesn't have much flexion of the arms and legs. This is fully developed. You see the difference in the flexing. And then the wrist sign, fully developed, they can bend the wrist. And this is premature when they pull the arm across. And then looking at the bottom of the feet, there's lots of wrinkles on a mature, fully developed newborn. Premature, you don't have much cartilage around the ear, and then full gestation, there's a lot of cartilage. Okay, now I can go back. So I'm gonna have you fill out your paper. Where the two big boxes are for neuromuscular maturity. At the top, it says gestation by dates. And write in 24 weeks. This was a preemie at Broward Health. For neuromuscular maturity, for the posture, put an X in the box under number 2. Did everybody find that? Okay. For the square window on the wrist, put an X for number 1.
So X in the box under number 2.
So posture, number 2 is an X in it. And then the next one, put an X in the box for number 1.
Underscore.
It's negative.
Yes.
Popliteal angle gets a 0. I didn't I? Okay, you can go back. Arm recoil gets a +2. Scarf sign. Scarf sign gets a -1. And heel to ear gets a 0. And then in the next box for hair on the body or lanugo, the skin is sticky, friable, and transparent, so put an X in that box. There's faint red marks for plantar surface.
So you put none for lanugo?
Lanugo is none.
Okay.
Faint red marks for plantar surface.
Does lanugo and skin always go hand in hand? I'm sorry, I didn't catch it.
Yeah.
Okay.
Faint red marks, breast barely perceptible. So put an X in barely perceptible. Eyes and ears, well curved. In a soft but ready recoil. So that's the 4th box for eyes and ears. Male genitals, the scrotum is empty. There's faint rugae. Rugae are folds. And now add up your score and see what the neuromuscular and physical maturity add up to. So add total all your boxes that you checked.
Is the scoring for the physical maturity the same as the neuromuscular?
Yeah, the -1 lines up, the 0 lines up.
Right? I got 1. Don't you have the negative, so it would make it 1?
Yeah, so subtract 1 for the -1, you subtract 1 from the total.
It's still 5.
I did, I still got 5. I got 4. I got 5.
I got 5.
5.
4. So 2, 4, 5. I got 5.
Minus 1 because it's still
9.
4.
Exactly. Oh, you mean all together? Okay, 5. I thought you just meant for neuromuscular.
Yeah, both boxes, add them all up.
Yeah, 5.
Okay, so now look at the maturity rating, find the score of 5. And how many weeks of gestation according to our assessment?
26.
26. Very good.
But the original one was 24 weeks. Right?
Yeah, according to mom's history, it was 24 weeks, but according to the gestational age assessment, it was 26 weeks. Okay, and then flip it over on the back. Another thing we look at is how tall the newborn is. So for length, this baby was 31 centimeters. And it's the below the lowest black line is under is considered small for gestational age. Above the boldest black line is considered larger or large for gestational age. So this baby at 26 weeks, look for 31 centimeters and put a dot. That's right on the edge, isn't it?
31 to 31.
So go down 26 weeks until you see 31 centimeters and put a dot.
It's 10%.
Yeah, so even though they're born prematurely, they're smaller than they should be for that age. Head circumference was 21 centimeters. So find 26 weeks, go down and put a dot for 21 centimeters. Again, small for gestational age. So 26 weeks. So in between 0 and 22, let's do that.
So where's the head circumference?
The head circumference, go down 26.
From here.
Head circumference is here.
Oh. 26.
Mhm.
Um,
Mhm. And their weight is 574 grams. So that's the box at the bottom left, 574 grams. So go down from 26 and find 574 grams. Which would be like right underneath 600, I guess. So it falls right on that bold line for me. You feel the same? So we would consider that small for gestational age. And then if you look on the bottom, do you see your choices? You have large for gestational age, appropriate for gestational age, and small for gestational age. So we come to the conclusion that this baby is small for their gestational age. So that just means that it was born prematurely, but for that age of prematurity, it should have been more developed. So small for gestational age. And then just to remember the names. So it's Dubowitz testing. It's called Ballard scale. And then gestational age assessment, which I like the best. So if you see any of these three, it's just referring to looking at the newborn to see how developed they are and determining whether they're average for gestational age, large for gestational age, or small for gestational age. Yeah, there's just like one multiple choice question on the exam with this. You don't have to do this on the exam. I just wanted to give you an idea of what they do when they're doing the assessment. All right, that ends that PowerPoint. And now I'll pull up the next PowerPoint. All right, so we're going to go through the different, I don't know if diseases is a good word. When I hear disease, I think of, getting an infection or acquiring something. But with newborns, there's different problems that arise, and that's what we're going to go through.
So conditions.
I like that better, conditions. The first one we're going to start off with is respiratory distress syndrome, RDS. When babies are born prematurely, if they're less than 28 weeks of gestation, there's a 60 to 80% chance that they'll have RDS. And then RDS is insufficient amounts of surfactant. So if the surfactant, it becomes present early on, what do we say by the 26th week of gestation? There is surfactant in the vesicles, in the type 2 cells, but the surfactant hasn't matured yet. So mom is given steroids, the steroids will go through into the fetus, and the surfactant will develop, and we won't have to give them surfactant once they're born. However, if they are born and they don't have that mature surfactant, they're going to be in respiratory distress. So it increases alveolar surface tension. So without surfactant, instead of alveoli staying open, the walls are attracted to themselves and they collapse. And that causes a decrease in lung compliance. When you're looking at a chest x-ray to determine if the infant has RDS, you'll notice that you see like a hazy appearance. And the reason that it's hazy is that there's so many collapsed alveoli. So collapsed alveoli make the lung tissue more pronounced, and that's why it looks more white. And it makes the conducting airways really stick out behind that white background. So if you look, you can see the main stem bronchi, you can even see the lobar bronchi. And the question is, how come you can see it so well? And the answer is because of all the collapsed alveoli, it makes the conducting airways stand out more. So when you can see the conducting airways really well, it's called air bronchograms. So let me put that in the chat. It's air, it's not. So ARDS in adults, you have lack of surfactant. Thank you, Danielle. It's true, ARDS, it has different causes than what you get in the newborn. But lack of surfactant does lead to alveolar collapse in both situations. So there would be that one similarity. Lack of surfactant in both situations is going to cause alveolar collapse, but the reasons are completely different. So air bronchograms, it means that the conducting airways are easily seen. And the reason the airways show up so obviously is that lung tissue is more dense because of alveolar collapse. All right, so how do you treat this alveolar collapse and not enough surfactant? One way is by delivering positive pressure to the airways. Positive pressure is going to keep the alveoli open. So since infants are obligate nose breathers, it's easy to put prongs in just their nose, and we're able to maintain the positive pressure like that. So nasal CPAP. Exogenous surfactant. I feel like we talked about this recently. The word exogenous just means from outside the body. So when you deliver surfactant, you get it from the pharmacy and you draw it up and you put it into the neonate's lungs. It's considered an exogenous surfactant because it was not produced by the infant themselves. So when we have surfactant in our lungs, that's considered endogenous, like our body created it. Exogenous would be we're delivering it to the body. So exogenous surfactant. I used to have like the students would all present a neonatal disease, and it was, I don't know if it was fun, but you had to create a PowerPoint, give a presentation of the disease. But when it came down to it, when you're looking up something, all you see is a bunch of information. You're not sure how much information is relevant, what's not relevant. The students were not doing well on the exams for neonatal diseases. They weren't doing well at the clinicals when they were being quizzed. So I've changed the format, but this was one of the students' presentations. So I kind of took it from a student. It's showing the pig and the cow. So when you're delivering surfactant that came from ground up cow's lungs, it's called Infrasurf or Survanta. That's not spelled right. Or it's from the pig and it's called Curasurf or Porrectant alpha. The dose is 2.5 milliliters per kilogram of body weight. And usually I don't emphasize dosages, but you guys get quizzed on this so often. So make sure you remember 2.5 mLs per kilogram. And I didn't check this before I started lecture. Let me make sure it's working. Yes, it is. So this is from the Curasurf website. So you don't know if you should believe it or not, because could it be biased studies that they're showing since it's their website? But they explain why you have better results if you use Curasurf compared to Survanta or Infrasurf. So it's showing the first dose. When you repeat the second dose, you give half dose. This is showing all the chemicals that are in surfactant. And what else did I want to tell you about that? I think that's good.
They'll intubate just to deliver this surfactant.
Yes.
Do respiratory therapists do that?
Yes. Yeah, most likely you'll see it when you're doing your neonatal rotation. You'll see them giving surfactant. So you push some surfactant in, give them a few breaths, turn them to the right, push some surfactant in, give them a few breaths, and then turn them to the left, push some surfactant in.
Why does it have to be can't just do it like MDI or something like that? Does it have to be because the tube goes all the way down to the
Yeah, you don't want it in that kind of upper airway. You want to make sure that it gets delivered to the lower airway. So it says to intubate, put the surfactant in, and then extubate within 5 to 10 minutes. So don't keep them intubated just because they had to have surfactant.
Will they know what baby is ready to be extubated?
That's a good question. So when they're ventilating on lower vent settings with good blood gases, they don't go down less than 10 breaths per minute when they're weaning. And you don't see a lot of sternal retractions occurring, then they're ready. Good O2 sats.
So you wouldn't do like with adults, you have to do NIP, vital capacity, SBI, that's not the case with.
That's not the case, you're right.
You can't coach them.
Right.
Yeah, they tell them to take a breath.
Right.
Still on event 3 years later. We need you to take a deep breath. O2 sats, blood gas, and work of breathing. Yeah. All right, so what I'm looking for, and I will find it, maybe it's coming up on another slide. Oh, here it is coming up. I found it. So here's the link for a video that talks about infants born prematurely and how they develop respiratory distress right away. And what should you do? So they recommend if they're in respiratory distress, they're premature, requiring FiO2 greater than 30%. That indicates that they need some surfactant. So you intubate, give the surfactant, and then extubate. So they call that the INSURE strategy. So you get extra credit, Chris.
It's on the next page.
Oh, okay.
That's what.
You get 10 points extra credit if you watch the video and then submit an outline of the topics discussed. And the outline typically takes about 2 pages. So if you hand in a half of a page, you're not going to get the 10 points. It's about 50 minutes of watching and taking notes, and then you submit that. So kind of puts together everything that you need to know for bedside care of the neonate. So that's why I'm putting a lot of stress on it.
Okay.
Is that substantial? You have 2 weeks.
2 weeks from now?
Yes.
2 weeks.
Um, 19 and 14 is 33. So October 3rd. Let me just check the calendar. Oh, there's Yes, October 3rd.
Minimum, 2 pages, till October 3rd. Is there anything else?
It can, you can submit it online. So if you handwrite it, then you have to take a picture of it, save it as a PDF, and then upload it. Or you can just type it as you're listening to it and then submit that.
It's almost like a dictation of the.
Yeah. Yeah, pretty much. Yeah, it's just a way to get you to connect with the information, spend some time with it, and it sinks in a little bit more.
Remember what? Was me, but I didn't do that. I tried. It was hard.
To get 2 points.
Yeah, on the extra credit you gave us. Your mechanical ventilator. I tried so hard.
Packet you gave us.
Oh, no kidding. Was it like a packet?
Yeah.
Yes.
It was 100% packet, but each packet was only $2.
I looked at it and said, I'll just study.
You spent hours on that to get it.
That's what I'm saying, like, give effort to what's presented.
Yeah, so my thought with extra credit, I mean, you guys are now in your 2nd year, you've obviously proven yourselves. But prior to your 2nd year, to survive on extra credit and get a passing grade when you really don't understand the concepts and you really aren't learning properly, that's why I don't give extra credit. I'll give 2 points just to say, okay, I'm giving you something for this effort. But the extra credit is just meant to help you learn. It's not meant for you to get a passing grade. So that's why I've always stayed away from extra credit. But now there's going to be extra credit coming. So,
My attention.
I see.
After all the anxiety. and last year.
If the fetus is at high risk for being delivered prematurely due to mother going into labor, then delaying labor and delivery is attempted by giving the mother tocolytics. So you don't want them to be born prematurely. They do a lot better if they can stay in utero as long as possible. But if it's not possible to delay labor and delivery, or if there's fetal distress, then glucocorticoids are given to the mother at least 48 hours before delivery. So if they go into labor and the baby has to be delivered now, they're not going to have a chance to get those steroids.
And glucocorticoids make the surfactant mature? or-
Yes. Mhm.
Somebody actually do research, that's great, and you're right, it is great, who studies these things and finds how, like, it's brilliant minds.
It was like when we crush up the cow big ones. It's a human being.
Which of the following are side effects of surfactant administration? Is a pneumothorax a side effect of surfactant administration? It could be, because you have a rapid change in compliance. So it is possible that, the pressures that you were using on stiff lungs are now being delivered to compliant lungs. It overstretches the alveoli and the alveoli pop. So it is possible. What about decreased compliance?
No.
No, it's going to be the opposite. As the alveoli open and compliance improves, meaning that compliance increases. What about higher ventilating pressures?
No.
No, when you have more, oh my gosh, where's my words? The more compliant the lungs are, then you're not going to need as much ventilating pressure to deliver the volume.
So pressures and compliance have an inverse relationship.
Yes. And then do you get desaturation during delivery of the surfactant?
Yes.
Yes, because the surfactant is thick. It's like dish soap or liquid dish detergent. It's pretty thick. And as it's going through the airways, it tends to clog up the airways until it finds its way through to the alveoli and gets absorbed. So as it's doing that, you'll notice that the O2 sats fall. So the answer is E, both A and D. Is it true or is it false? It is better to give surfactant to all infants born before 28 weeks gestation rather than wait for them to exhibit signs of RDS.
We wait.
We wait. When they have distress, that's when we say, yeah, I think we need to give surfactant. My mind doesn't compute that, but I guess not everybody is born the same. Some will need surfactant and some will be just fine without it. So why just automatically give it to everybody? A 25-week gestation newborn appears cyanotic, and the ABG analysis indicates hypoxia and hypercarbia. That should say indicates hypoxemia, right? Isn't that what we measure when we do a blood gas?
Yeah.
We measure the oxygen in the blood, not the oxygen in the tissue. So that should say hypoxemia. The infant has severe chest wall retractions with inspiratory effort. The amniotic fluid appeared normal at birth. What is most likely the cause of respiratory distress? Very good. Letter A, surfactant deficiency. So 25 weeks is extremely premature. And then you see chest wall retractions. You know that the alveoli are collapsing and it's making it harder for them to breathe. An infant diagnosed with RDS subsequent to lung prematurity is receiving oxygen therapy with an FiO2 of 0.8. Nasal CPAP is set at 10 centimeters of water. This is a bogus question. The infant is experiencing progressive hypercarbia and apneic episodes are appearing prolonged. The next logical course of action is to A, increase the FiO2 by 0.1. So that would be go to 90%. Start inhale nitric oxide. Increase nasal CPAP to 12. Refit the nasal prongs. Or D, intubate the patient and begin mechanical ventilation.
D.
Yeah, letter D. So how did you know that you need to intubate and start ventilating?
FiO2 can't be 90%. That's too high. And that cause blindness in newborns if you give them too much oxygen.
It causes blindness if the oxygen in their blood is high.
Okay, so that's for hypoxia.
Plus, if you give more than 30%, they probably need surfactant, right?
Yes, very good.
And then,
Yeah, nasal CPAP, typically you go up to 8 centimeters of water. And if that's not giving them a good O2 sat, then you intubate. Because to put 10 centimeters of water through the nose, that's so much pressure, they're not going to be able to exhale. So you would never put nasal CPAP at 10.
What about nitric oxide?
It's for pulmonary hypertension,
Mm,
which preemies don't have.
they don't-
So the correct answer is to intubate and begin mechanical ventilation. What are the radiographic findings typical of a child with RDS? Air bronchograms, ground glass pattern, and do you get atelectasis from the collapsed alveoli?
Yes.
Yeah.
It's D or?
2, 3, 5. D, letter D. All right, so that's all I have on RDS. So you see it a lot. Keeping babies on a ventilator worsens their outcomes lung-wise, and then the rest of their body also gets affected by that. So we don't want to intubate and put babies on a ventilator. That's why when you go through that ensure strategy, you're going to see how they just want to intubate, give the surfactant, and then extubate, give some nasal CPAP. All right, so in the next. So Corinne, what did we say we're going to use instead of disease?
Condition.
Condition. Write it down. Oops. All right, so putting babies on the ventilator, giving them oxygen, it causes damage to the lungs and they develop chronic lung problems. And it started off, what, 30, 40 years ago, where there was no surfactant to give the newborn. So they'd go into distress, you'd intubate them, put them on the ventilator, and they'd be ventilated for like 2 months of life. And it would just destroy their little premature alveoli. So their chest x-ray they would call it Swiss cheese by the time, they were a couple months old. There were so many busted alveoli, damaged lung parenchyma. So then once surfactant came about, you no longer saw this chest x-ray progression like you used to, but the name still sticks. BPD for bronchopulmonary dysplasia. It's referring to lung damage from chronic mechanical ventilation or even chronic lung oxygen therapy can cause BPD. Since it's not as severe now that we give surfactant, they changed the name. So in your textbook, they call it neonatal chronic lung disease. And then maybe in the medical record, when you're looking at how the physician will do a synopsis of problems, and they'll call it neonatal chronic lung disease, but most of the time they're still calling it BPD, so bronchopulmonary dysplasia. So BPD is an old name from the days when there was no surfactant and the lungs would damage the tissue. Now, if the tissue is damaged from mechanical ventilation, they still call it BPD. All right, so let me summarize that in the chat. Oh. Kind of repeating itself. So I wrote BPD is an old name for lung damage caused by mechanical ventilation and increased FiO2s. The name came about when babies are born prematurely and required mechanical ventilation, which destroyed their lung tissue.
Yeah. Like excessive.
Yes.
So they would still call it this if they develop lung damage and say like maybe, I don't know, 5 minutes if that's possible. Or is that not possible?
To be on the ventilator for 5 minutes
And
and
develop,
then, no, I don't
Okay.
think so. Well, I guess if enough pressure is used, yes. Premature neonates are subject to having underdeveloped lungs along with low surfactant production. They often require prolonged mechanical ventilation, which leads to inflammation in the lung tissue and tissue scarring. So what is BPD? It says chronic lung injury in premature infants who survived RDS after treatment with mechanical ventilation and oxygen. The more premature, the greater the incidence. So 30% of preemies less than 28 weeks develop BPD, but only 3% of infants born after 28 weeks. So it's preemies that needed mechanical ventilation and oxygen. It's those three things that came together. And then the bottom sums up what I already wrote. It says, although BPD is not as severe as it was before the days of surfactant, the term is still used.
We're gonna need to know those percentages, so they want to know that the more mature, the greater the incidence.
The more mature, the greater the incidence?
The more premature, sorry.
Yes, that's all you have to know. You don't have to memorize numbers. All right, so when you're looking at the chest X-ray, you see a hazy appearance. You see hyperinflation. You see how flat the diaphragms are. The diaphragm is. You see some round little black spots, and that's from cystic emphysema. Here's one that shows up really well. So that's the damage to the alveolar walls, and now you've got one big giant alveolus instead of many small little alveoli. So their lungs become like a COPD lung. Their blood gases are like a COPD blood gas, where they have chronic CO2 retention. It's showing old BPD on the left, and you can see how it's the black spots are more and they're larger. So that was ventilating without any surfactant being given. So BPD stands for bronchopulmonary dysplasia. It's abnormal development of lung tissue. It's caused by inflammation and scarring of the lungs. The end result is low VQ, meaning they don't ventilate as well because their conducting airways don't have the supporting structure. They don't have the good elasticity. And then here you can see how you've lost your alveolar walls, and now you've got like several alveoli together instead of all separate. ABGs become like a COPD patient where they have a compensated respiratory acidosis. That's a test question. You have to remember that. All right, so how is BPD diagnosed? At what point do we say, yes, they have BPD? Well, if they need oxygen therapy and continue to show signs of respiratory distress after 36 weeks of their gestational age. So they'll get weaned off the ventilator, but if they still require oxygen to maintain a decent O2 saturation, we come to the conclusion that they have BPD. So 36 weeks gestation. This could be like if they're born at 28 weeks. That's 2 months later. They're still requiring oxygen. Then they're going to be diagnosed with BPD. If they're still dependent on a ventilator, then we come to the conclusion they have BPD. And then, of course, their X-ray will look with all the hazy cystic appearance. So this goes into the same thing. It says the traditional definition of BPD was they need oxygen for at least 28 days after birth. But now they break it down. And they do mild, moderate, and severe BPD. Mild BPD is they need O2 for 28 days of life. Moderate BPD, they need more than 30% FiO2 at 36 weeks gestation. And severe BPD, they need more than, their FiO2 is 30% or more at 36 weeks, or they're still requiring mechanical ventilation at 36 weeks of gestation. So that's the definition. Do you have to know mild, moderate, and severe for your exam? And the answer is no. So on your exam, if the baby is requiring oxygen therapy at 36 weeks gestation, then they're considered to have BPD. So premature, ventilator and oxygen. And then going to 36 weeks of gestation, are they still requiring oxygen? Yes, then they're diagnosed as having BPD. Is that good? So you don't have to memorize mild, moderate, and severe. There is no definitive treatment for BPD, so you just manage, you monitor using ABGs, vital signs, give them nutrition. You prevent barotrauma, volume trauma by monitoring tidal volume and PIP. You prevent oxidative damage to the lung tissue by keeping FiO2s low. Okay, it's time for a 10-minute break. Okay, so it's not 10:43, it's 9:47. We're going to discuss PDA, patent ductus arteriosus. So we talked about this shunt occurring in fetal circulation because blood doesn't need to flow to the lungs in a fetus. So instead of flowing to the lungs, 90% of it crosses over this channel called the ductus arteriosus and goes directly into the aorta. And the picture shows it occurring. So you have blood coming into the right ventricle. And when the heart contracts, the blood goes through the pulmonic valve into the pulmonary artery. But then the pulmonary vessels are so constricted that not much blood actually flows to the lungs. And instead, the blood is going to take the pathway of least resistance, which is this open ductus arteriosus. So we're expecting that to close after birth when the pulmonary vessels dilate and the pulmonary vessels become the path of least resistance. So now all the blood is flowing there. The blood doesn't necessarily want to flow through the ductus arteriosus. So what two vessels does the ductus arteriosus connect? Very good. Pulmonary artery and aorta. So within minutes or days after birth, the ductus arteriosus closes, which is a normal change in newborns. It just becomes the pathway of least resistance, and it starts to close off.
Do they stay connected forever though, even though the duct's closed?
Yeah, it forms a ligament.
Okay, that's, yeah.
And this is showing an adult heart. It says ligamentum arteriosum. So that was the pulmonary artery, and now it's just a ligament between the pulmonary artery and the aorta. So after birth, pressure in the aorta is higher than pressure in the pulmonary artery. And do you remember a normal pulmonary artery pressure? No. Is it like 100/60? Is it 120/100? 40/20?
No, is it 20? Isn't it 20 over?
It's in 20, it's only very 20, 20/10. 20/10.
Very good. All right. It took you a minute, but you got there. So like 20/12. I remember 2 dozen over 1 dozen, so 24/12. But there's a range, like 20 to 30 is normal. Pulmonary artery systolic. 6 to 15 is normal pulmonary artery diastolic. Well, it's going to help you understand what I'm explaining. So in the adult heart, so after the baby's born and circulation switches over to adult circulation, you have higher pressure in the aorta and low pressure in the pulmonary artery. So if that ductus arteriosus stays open and it doesn't close, which way will blood flow? Will it flow from the aorta into the pulmonary artery, or will it flow from the pulmonary artery into the aorta? So you say pulmonary artery into the aorta? This is adult circulation. This isn't this is not fetal. Like they're born, circulation switches over to adult circulation. And if this ductus is still open, which way will blood flow?
Inverse from the aorta to
From the aorta into the pulmonary artery. Why?
yeah, because the pressure is high.
Very good. So aortic pressure is higher than pulmonary pressure. So if that channel stays open, you're going to get blood flowing from the aorta getting pushed back into the pulmonary artery. So if you have a patent means it remains open. Patent ductus arteriosus, it remains open. Blood is going to flow from the aorta into the pulmonary artery. So a PDA is when there's failure of the ductus arteriosus to close. The delay in spontaneous closure of the ductus is inversely related to the gestational age. So it shows that 20% of premature infants greater than 32 weeks. But in preemies less than 28 weeks, there's a 60% occurrence of the ductus not closing. So 60% of preemies have a PDA. So when with blood flows from the aorta back into pulmonary circulation, it's considered left to right shunting. So left side of the heart pushes blood into the aorta. And then the right side of the heart is where the pulmonary artery is. So that's where it gets its name, left to right shunting. It's going from the circulation of the left side of the heart into the circulation from the right side of the heart. It results in increased pulmonary blood flow. And then if you have excess amount of blood flowing in the pulmonary vessels, you end up with pulmonary hypertension. And if it's bad enough, it can even cause pulmonary edema because the pressure in the pulmonary capillaries becomes so high that it leads to pulmonary edema. So how is it diagnosed? It says with an echocardiogram. So they use ultrasound and take a picture of the ductus and any blood flowing across it. For treating it, it's possible that the PDA may just close on its own. So only if they're seeing pulmonary hypertension, pulmonary edema, do they say, you know what, I think we need to treat this. There's some drugs that can be given to treat PDA. The first one is ibuprofen. Isn't that amazing? Ibuprofen reduces prostaglandin levels. In the chat, I wrote, in the premature newborn, there is circulating prostaglandin. This keeps the ductus open. So that's why in these premature babies, we have the PDA staying open because they've got this hormone that circulates in their blood and it keeps the ductus open. So if we give ibuprofen, it reduces the circulating prostaglandin and then the ductus closes. I'm repeating what the slide says. So if they give ibuprofen, another one is indomethacin. It's another drug given. It'll reduce it. And if it doesn't, then they're going to put an opening in the thorax and go in and put a clip around the pulmonary artery and physically close it. As far as cutting it, I don't know if they cut it. I mean, here it says PDA ligation, but I think they just put a band around the pulmonary artery and that's tight enough to reduce the blood flow. I don't think they cut it. They might call it PDA ligation, but they're really not cutting it. Can you imagine cutting something in the aorta? The pressure and the bleeding and so they might call it ligation, but I think all they do is put the band around it. Question, normal transition to extrauterine life depends on the pulmonary vascular system, A, remaining in a steady state of balance with hepatic blood flow. Oh, that's a bunch of beeswax. B, changing from low pulmonary vascular resistance to a high pulmonary vascular resistance. No, it's opposite, right? Changing from high pulmonary vascular resistance to a low pulmonary vascular resistance. Does that sound correct? Yes. And then maintain a patent ductus arteriosus. No, we're counting on it closing. We don't want it to stay open after birth. Number 2, which of the following affects pulmonary vascular resistance? Changes in PaO2, changes in PaCO2, changes in pH, all of the above or none of the above. This is like going back to your first semester of the program, isn't it? What affects pulmonary vascular resistance? So if you have hypoxemia, what does that do to the vessels around the pulmonary arteries? It constricts them. Yeah, that's why patients that have COPD and their oxygen levels are always low, they end up getting pulmonary hypertension eventually. It's because their vessels are always constricted, and then their right heart fails because of it. So yeah, low O2 constricts pulmonary vessels. Same thing with high CO2. High CO2 and acidosis constricts pulmonary vessels. Do you need that in the chat, or you remember that?
So it'd be all of the above?
All of the above, yes.
First question. What was the first question?
Let me go back. Letter C. You're welcome. What medication can be given to an infant to facilitate closure of a patent ductus arteriosus? Letter E, that's correct. You can give indomethacin, you can give ibuprofen, and that will reduce the circulating prostaglandins. Pulmonary edema in premature infants is a symptom of which complication?
C.
Very good. Letter C. So if they have a patent ductus arteriosus, there's a lot of blood flowing from the aorta getting into the pulmonary artery. And all that excess blood flow in the pulmonary vessels can lead to pulmonary edema. Blood flows from where to where in a premature neonate with a PDA? Very good. Letter A, aorta to pulmonary artery. Right, so that was it for PDA. Next, we get into persistent pulmonary hypertension of the newborn. And then our background story is we know when a fetus is in utero, we don't have a lot of blood flowing to the lungs because the pulmonary vessels are so constricted. So the pulmonary pressures are very high in utero. Once they're born, the pulmonary artery pressure should drop down to normal. But sometimes it doesn't. Sometimes those pressures stay really high in the pulmonary vessels after they're born. And it's called persistent pulmonary hypertension of the newborn, PPHN. PPHN is found in infants that are term or post-term. It says preemies don't have smooth muscle around their pulmonary vessels, so they can't develop PPHN. So this is a condition of full gestation newborns, not preemies. It is brought on by anything that causes hypoxemia in a newborn. And when you're reading in your textbook, there's a chart with a huge list of things. But the bottom line is all of this stuff leads to hypoxia of the newborn. Once the oxygen level is low, pulmonary vessels constrict and they stay like that. So how do we get these pulmonary vessels to relax when they're so constricted? And we'll talk about that. Pardon me. Does this kind of help bring it into perspective? There's hypoxia. It causes the pulmonary vessels to constrict. That causes pulmonary hypertension. And then we get shunting. And now we have shunting going from the right side to the left side. So going from the pulmonary artery to the aorta. I'm going to write that in the chat. So with PPHN, blood is shunted from the pulmonary artery into the aorta. Do you see how that's completely different from when we were just talking about a patent ductus arteriosus? With that one, we had higher pressure in the aorta and it was pushing blood into the pulmonary vessels. But now the pulmonary vessels constricted, pressure's so high, it's higher than what's in the aorta, and that's causing blood now to go from the pulmonary vessels into the aorta. So it's opposite from what we just talked about. Okay, let's see if we have another picture coming up. Yeah, there's a picture coming up. First, it says heart echocardiogram shows that the heart has no defects. There's nothing going on inside the heart. So no intracardiac shunting. However, there is severe hypoxemia. So if they have a PaO2, why do they have to have 0.5? Are you serious? A PaO2 of 37.5 and 45 on an FiO2 of 100%. Evidence of right to left ductal shunt. And now we look at preductal and postductal. So I'm going to explain to you preductal and postductal in a second. And then there's a difference of 20 millimeters mercury between them. All right, so this is showing the aorta and where the ductus arteriosus is located. It's located kind of where the aorta starts to arch downward. So when you have deoxygenated blood in the pulmonary artery and the pressures are so high, it's pushing the blood into the aorta. The blood enters the aorta. Okay, what are the names of these three vessels? So brachiocephalic, left common carotid, and what is this one called? Left subclavian? Do you guys remember the name of this? I swear I'm going to retire in 2 years and still don't have this memorized. Every time I come to this, I struggle. So brachiocephalic, it goes, brachio is arm, cephalic is head. So brachiocephalic is the first one. The first branch off of the aorta is getting the freshly oxygenated blood from the left ventricle. So the heart contracts, it's going to send the good oxygenated blood into the aorta. So the right side of the head, the right arm, it's going to get the freshly oxygenated blood. I don't know why I stick the word fresh in there. I don't know if there's stale blood, but freshly oxygenated. I don't know, it sounds good, I guess. The left common carotid artery kind of gets a little bit of a mix. So if we want to know how well oxygenated the lungs are doing, we would look at the blood flowing from the brachiocephalic artery. That's going to be our truest view of blood from that went to the lungs and came back to the left heart. The other two are kind of, they get mixed up in this shunting that's going on. So they're not reliable as far as looking at how well the lungs are oxygenating the blood. And that's why on newborns, we always put the pulse oximeter on the right hand. Putting it on the left hand, there might be some shunted blood mixed in with that blood flow. It's not going to be an accurate representation of what the lungs are doing. Put it on the right hand, yes, it's going to be an accurate representation of blood that came from the lungs to the left heart and then got ejected into the aorta. So that's considered pre-ductal. So it's before the ductus arteriosus. Everything else is considered, well, this is kind of mixed in the middle, the left common carotid. But anything after that is considered post-ductal. So you're going to hear this on like every baby in the neonatal ICU. You're going to have pre-ductal O2 sat and post-ductal O2 sat. And this is what it's referring to. So pre-ductal is the oxygenated blood coming from the lungs. That's going to be your highest or best value. And then post-ductal is going to be after the ductus arteriosus. And if there's any shunting going on, you're going to see a value that's lower than the right radial. So post-ductal blood may have a lower oxygen content because of shunting. Post-ductal blood may have a lower oxygen content. This is due to shunted blood from the pulmonary artery mixing with oxygenated blood. So here it says the pre-ductal blood, if it's 20 millimeters mercury more than post-ductal blood, then you have pulmonary hypertension occurring and shunting occurring.
That was the pressure you were talking about.
All right, for post-ductal, it says umbilical artery. Post-ductal is anything after the descending aorta. So what about blood flowing to the legs? Do you think that's pre-ductal blood or post-ductal blood? That's post-ductal. Blood flowing to the umbilical artery, post-ductal. Flowing to the left hand, sometimes it's mixed and that's not a good O2 stat to use. So it's better to use umbilical artery and legs. Just putting like a pulse ox on the right hand and left hand. Left hand is not a good indicator of the amount of shunting taking place. Are you still going to see it? Yeah. If there is indeed persistent pulmonary hypertension occurring in a full-term newborn and deoxygenated blood flow is being shunted across the ductus arteriosus into the aorta, would you expect the right arm to have a higher PaO2 or a lower PaO2 than the umbilical artery? Higher, very good, letter A. It's going to be higher because the shunt occurs after that point on the aorta. How do we diagnose PPHN? Well, an echocardiogram can be used to detect the flow of blood across the ductus arteriosus. We can look at pre and post ductal PaO2. And if we have a difference of 20 millimeters mercury, then we know we've got shunting. Hyperoxia test is putting the baby on 100% oxygen and still their O2 sats don't increase. And that's because the shunted blood is blood that never went to the lungs. So giving them 100% is not going to improve anything. So hyperoxia test. So I wrote, with the hyperoxia test, if the PaO2 improves, that indicates it is a problem in the lungs and it's not a shunt. Because with a shunt, no matter how much oxygen you give, the blood isn't flowing to the lungs. It's flowing across the ductus arteriosus. So you give 100% and you have no change in your oxygen saturation. That says, yes, you have a shunt occurring. So if you ask about the hyperoxia test when you're in doing your rotation in neonatal ICU, they'll tell you they don't like to use 100%, so they don't do the test. But if you take your NPS exam to become a neonatal pediatric specialist, they're going to ask you about the hyperoxia test, or they'll mention it. And you have to at least know what they're referring to. If you have 100% oxygen on the baby and still oxygenation doesn't improve, that indicates there's a shunt going on somewhere. Olfactory?
No, refractory.
Refractory hypoxemia, very good. And then they can do a hyperoxia hyperventilation test. And this is hyperventilating the neonate. And when you hyperventilate and you cause a respiratory alkalosis, that will relax the pulmonary vessels. And then you'll see the shunting stop being so severe. So hyperventilation dilates pulmonary vessels. So hyperventilation dilates pulmonary vessels. So if you hyperventilate, hyperoxygenate, and then the postductal oxygenation improves, that's how you diagnose PPHN. All right, so how do we treat this? We have constricted pulmonary vessels. We want to get them opened up. So they will intubate, put them on the ventilator. You may use high frequency ventilation. That way you're protecting the lungs from barotrauma. High frequency ventilation is more gentle to neonatal lungs compared to conventional ventilation. And then you can give nitric oxide. It's a potent pulmonary vasodilator. So we have a lecture coming up on this. Inhaled nitric oxide. It'll relax the smooth muscle around the pulmonary vessels, and then you'll notice your shunting goes away. ECMO used to be done before nitric oxide was a thing. So even though it's listed here, it's typically just do nitric oxide to relax the vessels. Okay, we'll talk about meconium aspiration. And this shows poop getting into the airways. And that's what meconium aspiration is. So meconium is the first poop that a newborn has. And sometimes they poop in utero before they're born. And if they do, remember that amniotic fluid goes in and out of the airways. So the poop can go into and out of the airways also.
So why would they poop? Is it because they've gone past 40 weeks of pregnancy? Or, yeah.
That's a possibility. Yeah. Anything that stresses them in utero can cause them to poop in utero. And it's tar-like, it's very thick, very sticky. So when that gets into the airways, it can really plug up the airways and cause some problems. It's made up of amniotic fluid, salt, intestinal tract secretions, bile, intrauterine debris. This is something that occurs in full-term or post-term infants that have hypoxemia. I don't like the way that's stated. The way that's stated, it makes it sound like they're born, they have hypoxemia, and then they aspirate their meconium, doesn't it? So that's not correct. Let me get rid of that. Allow me. So it's hypoxemia in utero that stresses the fetus. The anal sphincter relaxes and meconium is passed into the amniotic fluid. So anal sphincter relaxation because of stress. I guess that's the connection. And then gasping inspirations force the amniotic fluid into the glottis and airways. The clinical signs and symptoms, if you see meconium staining on the skin, nails, umbilical cord, wrinkles, and creases in the skin, and it's showing you like a green tinged secretions, so that's meconium in the amniotic fluid. I don't know if they know this, but I don't think that valve opens with spontaneous breathing. I think you need to be pushing air. Or maybe they're, I don't know, let's not guess what they're doing. It says, watch for signs of distress. Only with distress is the infant intubated and the meconium suctioned from the airway. So it occurs, I don't know what the statistics are, like 1 in, I don't know, 1 in 100 babies or something have meconium. But only maybe 1 out of 100 will have any issues with it getting into the lungs and causing problems in the lungs. So it's it occurs frequently, but there's not that often are there complications. I need to explain to you what the ball valve effect is. So when the meconium gets into the airways, do you remember in pulmonary function, we were talking about during inspiration, the airways open up a little bit, and then on exhalation, they close a little. So on inspiration, air can get past the meconium, but on exhalation, when the airways close a little bit, it closes around the meconium and air gets trapped. And then the next breath, they breathe in, air can get past the meconium. On exhalation, it can't come back out, it's trapped. That keeps happening for several breaths, and then the pressure in the alveoli gets so high, it pops open alveoli. So they get a pneumothorax as a complication of meconium in the airway. Yes. So bowel valve effect of meconium, air can get past the meconium during inspiration, but during exhalation, the airways close slightly and trap the air. So when you have a lot of air trapping, it does press down on the diaphragm. So you see flattened diaphragms from the air trapping, pneumothorax, hyperlucent, lots of air, I guess from the air trapping. So I just want to read what's in orange. But it doesn't say where this came from. I think this is American Heart Association, neonatal advanced life support. No, I got to read the whole paragraph here. Because the presence of meconium stained amniotic fluid may indicate fetal distress and increases the risk that the infant will require resuscitation after birth. A team that includes an individual skilled in tracheal intubation should be present. If the infant is vigorous with good respiratory effort and good muscle tone, the infant may stay with the mother to receive the initial steps of newborn care. Gentle clearing of meconium from the mouth and nose with a bulb syringe may be done if necessary. So that's a big change from prior, where it used to be, okay, you see this, the amniotic fluid comes out with this green color to it. Oh, the baby pooped, we've got an airway issue. Quick, let's use the laryngoscope, look at the airway, start suctioning. And now they're saying, no, let's wait to see if they have distress first. And then we want to be more vigorous with suctioning. And here it describes, it says, if the infant is born through meconium stained amniotic fluid and has poor muscle tone, inadequate breathing efforts, you do your initial steps of resuscitation and the radiant warmer. Positive pressure ventilation should be initiated if the infant is not breathing or if the heart rate is less than 100 per minute after the initial steps are completed. Routine intubation for tracheal suction in this setting is not suggested because there is insufficient evidence to continue recommending this practice. So what should the message be in your mind? Just so you don't have to memorize so much. All right, the infant's born and you see meconium stained fluid, what should you do? Very good. Very good. And then if they don't, so Put them in the radiant warmer. Yeah, doesn't it say less than 100? You start PPV?
And then suction. So,
And then if they don't, if their respirations continue labored and you need to intubate, then yes, that's when you suction. Okay, so meconium aspiration is diagnosed when we see meconium stained amniotic fluid. And then if you are intubating, you'll see the meconium in the trachea when you go to suction, when you go to intubate. And this is just repeating what we said. If the infant is vigorous, and vigorous means they're moving their arms and legs, they've got good respiratory effort, good heart rate, we just observe. But if they're not vigorous, they have depressed respiratory effort, they have poor muscle tone. It says at this point, you clear the secretions with a bulb syringe and begin PPV if the heart rate is less than 100. Intubate only if necessary. Suction the airway when visualizing the cords. If you're going to put them on a ventilator with severe aspiration, you end up putting them on the ventilator. It says to use low ventilating pressures, short I time, and long E time. Does it make sense to choose low ventilating pressures? Why?
to avoid bowel trouble or pneumothorax.
Yeah, so when you're using higher pressures, that's more air you're pushing past the meconium, higher the chances that they're going to get a pneumothorax from that. And then the longer E time to let that trapped air come back out. And then surfactant may help. So an infant is born with meconium staining the skin and in the mouth. Respirations are unlabored. Heart rate is 120 per minute. Skin is pink. You would recommend do nothing, suction, intubate, and place on mechanical ventilation.
Do nothing, observe.
Very good. Letter A, do nothing and observe. A 40-week gestational age infant is born via C-section. Meconium stained amniotic fluid is present. The newborn is flaccid. Heart rate is 90 per minute and is having gasping respirations. You would immediately A, suction the mouth and nose with a bulb syringe. Begin positive pressure ventilation for a minute. Do nothing and observe. Use the laryngoscope to visualize the vocal cords. Suction if meconium is present, and then intubate.
I'm gonna say A,
Very good. So it's letter A.
but if it doesn't improve, then it would become C.
Yes.
So A.
All right, take a break. All right, we still have neonatal pneumonia to discuss and congenital diaphragmatic hernia to discuss, and then we're done. So hang in there. So for a neonate to develop pneumonia, there's certain organisms that typically cause the pneumonia. First one is group E streptococcus. That's an organism that's typically like normal flora of the vagina. And they come in contact with this bacteria during delivery. E. coli is frequently present in feces. Staph aureus is frequently present on the skin. Pseudomonas is just contamination from poor hand washing. So the pneumonia can occur prior to birth, where there's organisms that cross from mom's blood across into fetal blood. The second way is aspiration can occur during delivery. And third, pneumonia can be acquired after birth, just from getting contaminated somehow. All right, so early onset, if we have a pneumonia that develops at birth or within the first week, it says it could be caused from transplacental acquirement. Is that a word? And it lists some viruses, CMV. What is it? Cytomegalovirus, human papillomavirus, herpes, toxoplasmosis. Toxoplasmosis comes from mom cleaning cat litter boxes or from cats. And they inhale the parasite, it gets into their blood, it crosses over the placenta and can affect the fetus. Pneumonia can occur during the perinatal period. Perinatal means around the time of labor and delivery. Pardon me, it says PROM. So where's my little chat? You need to know what PROM is. Premature rupture of membranes. So if the amniotic sac that the fetus is in, it breaks, like right before labor begins, times that the membrane will break and then labor starts. But if the amniotic sac breaks and labor doesn't begin, and it goes on for several hours, it's possible once that sterile fluid is no longer surrounding the fetus, microorganisms can migrate up into the fetus and infect the fetus. So they'll be born having pneumonia and they'll be very septic.
For some women I hear who have like 24 hours of labor, is that like more susceptible for them then? Or?
Yeah, so as soon as the membranes break, I think the clock begins ticking. I think they start them on antibiotics. Once it hits like 12 hours or so many hours go by, they'll start them on antibiotics at that point. So sometimes labor occurs and then late in labor is when the amniotic sac breaks. Sometimes before labor, the amniotic sac breaks. And then aspiration can occur during delivery. And if it does, it's typically group B streptococcus, because that's the microorganism that is in the vaginal tract. If the pneumonia occurs after 4 to 7 days, that means that they acquired the pneumonia after they were born. So that's considered postnatal pneumonia, or a nosocomial pneumonia if they're in the hospital. So it's treated with antibiotics, or if it's a virus, antivirals, oxygenation, ventilation, pharmacological support. Yeah, I think we covered everything. So do they get beta strep pneumonia transplacentally? Does it, is beta strep pneumonia contracted across the placenta? Very good. So that's gonna happen when? Yes. During the birthing process. What about toxoplasmosis? Does that occur during birth? Does that occur 4 to 7 days after birth? That's transplacenta, so they'll be born with it. Okay, what is ascending vertical transmission? So if bacteria is obtained, ascending vertical transmission, what do you think that means? Yes, that's from the vagina up into the baby. So that must be when the membranes rupture. They can acquire ascending vertical transmission infection. Okay, I think we covered everything.
Question. So
Yes,
before birth, they do not make sure that the mom doesn't have any infection?
yes, they do.
Oh, so
Yeah.
it's not easy for a baby to get that ascending vertical infection, right?
Correct.
Okay.
So going on antibiotics, so if they culture mom and put mom on antibiotics, does that knock out all? Does that sterilize the vagina? I don't think so.
No. Because usually it takes like 7 days to be on an antibiotic for UTI,
Yeah,
and not instantly.
so, yeah, going on an antibiotic doesn't necessarily mean that the baby won't have a pneumonia. A 4-day-old infant born at 27 weeks gestation develops recurrent symptoms of RDS. The infant had been removed from mechanical ventilation and extubated at day 3, was receiving nasal CPAP with an FiO2 0.4 when lung function acutely worsened. Chest radiographs show a widespread diffuse granular pattern. Analysis of arterial blood samples shows O2 stats are refractory to high FiO2s. The most likely cause for these recurrent symptoms of RDS is, and of course, since we're on the pneumonia section, the answer would be postnatal pneumonia. When an infection is acquired postnatally, the radiographic findings often change from normal to severely abnormal over the first few days. Depending on the severity of the disease process and required treatment, pleural effusions, pulmonary edema, pneumatoceles, cardiomegaly, evidence of barotrauma may be seen. And ABGs will show the baby refractory to oxygen therapy and hypercapnia. So in other words, they get really sick from pneumonia. A newborn infant begins to develop signs of respiratory distress at 5 days of life. A cerebrospinal fluid culture tests positive for beta streptococcus infection. Which modes of transmission is most likely the cause of the infection?
Postnatal, I'll say postnatal.
Is it A?
Not sure you can get beta streptococcus infection through the placenta. So I would say no to A. Yes, letter C is correct. Perinatal or postnatal. So peri is around the time of delivery. So if membranes rupture, the organism can get up into the fetus. And then postnatal, they come in contact with the organism and then they develop a pneumonia. The infection occurs most often in very low birth weight infants. The connection is the more premature they're born, the less their immune system has developed. So this pneumonia does progress rapidly to shock. So if they go into septic shock, what are some signs and symptoms of septic shock? Very good. Low blood pressure. Okay, last one is congenital diaphragmatic hernia. It's a birth defect that causes the abdominal organs to take up space in the thoracic cavity. And I want to show you an X-ray first. So what you're looking at is the intestines are up inside the thorax.
Oh.
So
That's different.
normally during fetal development, the diaphragm has different leaves, I guess, that grow together. And sometimes instead of them growing together, the abdominal contents kind of push up through it. And then everything continues to develop. So the intestines develop, but they develop in the thorax, push on the lungs, and now the lungs can't grow and expand the way they're supposed to. So it does compromise how the lungs develop on the affected side, on both sides, actually. When you have all of this stuff in the left, it does push on the right also. So here you have just a big air bubble. So now you have a stomach up in the thorax.
Congenital diaphragmatic hernia, or CDH, is a birth defect that allows abdominal organs to pass through the diaphragm, enter the chest, and inhibit lung growth. This can cause breathing problems after birth. Let's take a closer look at the hernia. The chest is separated from the abdomen by a thin muscle called the diaphragm. Sometimes very early in fetal development, the diaphragm fails to completely form. This can cause some of the organs in the abdomen, such as the small intestine, stomach, or liver, to move into the chest cavity. These organs press against the lungs, slowing down the lungs' development as the rest of the body continues to grow. This can cause two main complications: pulmonary hyperplasia and pulmonary hypertension. The severity of this condition requires a comprehensive approach. At the Colorado Fetal Care Center, our dedicated multidisciplinary team has some of the best outcomes in the nation in caring for and treating CDH and its multiple effects. Visit coloradofetalcarecenter.org for more information or to make an appointment.
How do I stop it?
This is something I know is happening before the baby is born, right?
Good point, yes. So yeah, it's, oh, I didn't stop it. Yes. Oh, my word. Let me see what I can do to.
schedule the time. Are you still when that happened to?
Yeah.
You're the finger on everything.
Yeah. How many, what's the mortality rate for this? Like this? That'd be pretty high, I think.
Yeah,
When does that happen? Like at what stage in the gestation? Is it pretty late, I would guess, by the time everything's developed for it to happen? Cause my friend actually had a baby that happened to her. And they knew it, but they told her there's nothing we can do, so they basically had to schedule a time to give birth to. It still was gonna be, once the baby was born, it would die.
oh.
Yeah.
So it must have been really early on.
No, it was very late on.
Oh, really?
Yeah. Yeah, she did go through like the regular delivery process,
Oh,
but they knew, like, they told her the baby's alive now, but all the intestines are, on the outside, so once you give birth, the baby's going to die.
did they say the intestines are on the outside? Cause
I-
that's gastroschisis or
No,
omphalocele.
it was like, they were up, like,
Oh.
in the lung, yeah.
Wow.
So yes, I was just wondering if that's like mostly the case, that they don't, that doesn't happen till later on and there's nothing they can do, or are some of them able to be saved?
Yeah, I know they'll stabilize the baby first and then take them to surgery and pull everything back down into the abdominal cavity. But because the lungs didn't develop normally, they may end up on the ventilator for a long period of time. So I don't know how they can call that without trying to fix it first. Like how, at what point can they say, you know what, we're not going to be able to fix this?
Yeah, I don't know, maybe she didn't want her on a ventilator, I have no idea.
Yeah.
Would it have something to do with the size of the opening, like how poorly the diaphragm had developed, maybe?
I wonder, because was it just the stomach? Was it the stomach, intestines and liver? Because at that point, that's pretty severe.
Right. That's about it.
Yeah.
Are there some things, apparent parental traits or something that may cause this to happen, make it more prevalent?
Oh, that's a good point. Do you have your phone? Can you Google it really quick? Causes of CDH.
What if the hospital wasn't equipped for that kind of surgery?
Those doctors are unknown on the power.
They would send the mother
Yeah.
to another one, or they would keep the mother and say, okay, there's nothing we can do about it.
Keep the mother and just let the baby die after being born?
Yeah.
Probably.
Yeah. So I'm guessing if that would have to happen, they would have transferred the mother to give birth to a hospital equipped for that kind of surgery.
Right, that's true. So if they do fetal ultrasound and they see that they have the diaphragmatic hernia, then they can move the mother to a hospital that has the surgery.
Yeah, that's what I was thinking.
Like this place in, where was it, Colorado?
Yeah.
What did it say? Genetic abnormality?
So it says there's no specific cause, but it can come with genetic abnormalities and heart defects, so it makes it more common.
Oh. Wow.
That's unfortunate.
Yes, it is. Yeah, it is. So one thing that we have to know is when these babies are born, one way to recognize that if they didn't have ultrasound and you didn't know, the telltale sign is a scaphoid abdomen. Let me put that in the chat. Scaphoid abdomen means that the abdomen is really sucked in. And the reason it's so sucked in is because all of the abdominal contents are up in the chest. So if you see that, you don't start bagging, because as you bag valve mask the newborn, the air goes up into the chest. and squeezes the heart. And then within a couple minutes, they're gonna be dead.
Was it
So-
the second one?
What's that?
Was there thorax looking one?
Yeah, yeah. Yeah, they have like, it looks like a barrel chest almost. This is another picture of the intestines up in the thorax. So if you're bagging, that air goes into the thorax. So it follows the esophagus into the stomach, into the intestines, and it puts a lot of pressure on the thoracic organs. So what has to be done is a nasogastric tube has to be inserted first before you can start bagging. So the tube will be passed into the esophagus, it'll sit in the stomach and get hooked up to suction. So that as you're bagging, any air going into the stomach will be suctioned out. Factors responsible for the development of CDH are unknown. The pleural peritoneal canal fails to close. This usually closes at 6 to 7 weeks of gestation. Results with intestines and viscera entering the thorax, therefore compressing the lungs and heart at a crucial part of cardiopulmonary development. Compression of the lungs and heart lead to pulmonary hypoplasia, pulmonary hypertension, pulmonary immaturity, deficiencies in surfactant, and the antioxidant enzyme system. Emphasis is on the management of pulmonary hypertension and the hypoplasia. The infant is intubated after delivery and placed on pressure limited ventilation with permissive hypercarbia. So you're not going to try and shoot for a normal blood gas with these babies. Alternate means of support include high frequency oscillatory ventilation, extracorporeal membrane oxygenation, and inhaled nitric oxide, if unable to stabilize on conventional ventilators.
Okay, yeah, that, no,
Yeah, how did you know?
the tubes.
Yeah, so you see a tube taking blood away from the body, sending it to the membrane oxygenator, and then back into the body.
Why is it so red?
I think he's edematous because skin is shiny because he's retaining so much fluid. Surgery is 24 to 48 hours following birth, but it can be safely delayed for stable patients. Urgent surgical repair is almost never necessary. That's what I thought in my mind. Like as soon as they're born and they know that they have a congenital diaphragmatic hernia, then they're immediately, they operate and pull everything back into the abdomen. But that's not the case. They want to stabilize them first before they do the surgery, which means being able to ventilate them, oxygenate them, and then they'll do the surgery.
If they're unstable, you're gonna have, they have to be swinging, is that right?
If they're unstable, no.
So they're not-
No, so if,
so they're just gonna let it die, basically.
yeah, because if they die during surgery, it's a lawsuit.
Oh,
So, yeah, they need to be stable first and then they do the surgery. Long-term restrictive and or obstructive disease may be seen. They have failure to thrive. They have esophageal abnormalities. They have musculoskeletal impairment such as scoliosis, smaller than normal thoracic cavity on the affected side.
The quality of life is just.
Yeah, learning and developmental disabilities, 50% of patients.
50%, that's high.
Yeah. Which of the following are true concerning congenital diaphragmatic hernia? Is pulmonary hyperplasia present in both lungs? So, yeah, when there's a lot of pressure on one side of the thorax, it'll push all the contents over to the other side and will affect the opposite side also. You get persistent pulmonary hypertension as the main complication, yes. Surgical correction results in complete reversal of respiratory distress. That's false because the lungs didn't develop. You didn't get the right number of alveoli. You didn't get the conducting airways, the pulmonary vessels. CDH formation is a defect that occurs very early in gestational age. We found that 6 to 7.
Yes.
The right lung is not usually the site of the herniation. That's true. So on the right side, you have the liver sitting underneath the diaphragm, and that kind of stops things from coming up into the thorax. It can happen. There is a small percentage of CDH that does happen on the right, but most of them happen on the left.
Does it happen early enough to have an abortion?
Ah, yeah, I know. I asked you guys what the law is in Florida. So I guess if you're in Florida, no, you'd have to go to another state.
But yeah, I mean, you know how they usually. Well, I don't really know what it is, but like how many weeks?
Like 15, something
Allowed
like
to
that.
have an abortion?
Oh, up to 15 weeks.
Right now.
So yeah. So they could do an ultrasound and see the abdominal contents in the thorax. Yeah. Very good. Good point. (3,200 gram) term infant male born to a healthy mother. Scores are APGAR is 7 and 5. The infant is gasping, heart rate decreasing to 90. Physical exam reveals cyanosis, a scaphoid abdomen, and visible tracheal deviation to the right. Considering this information, the only appropriate action would be to get a blood gas, bag mask, ventilate, suction and stimulate vigorously, insert an oral suction catheter to vent the stomach, or vigorously stimulate and give 100% O2 blow-by.
D.
Very good. Insert an oral suction catheter to vent the stomach. Considering a likely diagnosis of congenital diaphragmatic hernia, which of the following would be an appropriate decision concerning ventilator strategy? Well, it's an underdeveloped lung.
B.
Rapid rate and low pressure, yes, very good. So keeping pressures low because we have less lung parenchyma, and then ventilating faster to blow off CO2 would be the best strategy. All right, you guys made it to the end.
End of part 1.